So it's a pleasure to introduce our next speaker, Dr. Ishac Nazy. You've already heard that Isaac he was born at McMaster. I think went to high school at McMaster. He did his medical training there. Actually, it's not all true. He's an associate professor at McMaster University. He's the co-director of the Michael de Groot Center for Transfusion Research. He actually received his bachelor's degree in physical sciences from the University of Guelph, and then did his PhD at McMaster, and then continued on there, where he's risen and rising through the ranks. He's really an expert in everything platelet, from immune thrombocytopenias, TTP, VIT in particular, a rare disorder, unfortunately, can be devastating, and he's really provided major insights into that. But I don't think he's talking about that. I think he's talking about heparin-induced thrombocytopenia today. So, Isaac, welcome.
I was born in Hamilton, but not at McMaster, at St. Joe's, for those that know. I did go to Guelph, but I didn't finish my honors there. I came to McMaster and finished my honors. So almost everything in Hamilton. Anyways, I'm honored to be here. To be honest, when I was telling my previous mentor that I'm coming to talk here, and he looked at the roster of speakers, he became quickly impressed because he saw Cedric's talking too. That's John Kelton, for those that know him. So I'm going to talk about heparin-induced thrombocytopenia, and it's pretty much my journey in this world of translational medicine, and I love it so much because when I talk to clinicians, I just say I'm a scientist, and when I talk to scientists, I say I'm closer to the clinic, so I don't have to answer all the questions. Anyways, these are my disclosures. And I'm going to talk about the pathophysiology of heparin-induced thrombocytopenia, how difficult it is to recognize the disease at the clinical stage, how difficult it is to diagnose it confirm it at the laboratory stage, and some of the novel approaches that we're taking, or one novel approach we're taking right now to improve on the diagnostics. So heparin-induced thrombocytopenia is an immune-mediated platelet disorder. It is characterized by thrombocytopenia. As many know, when you're using heparin, thrombocytopenia is prevalent, so it's hard to recognize the disease. And the suspicion of HIT is not created equally across the board because it depends on the clinical setting, be it medical, surgical, but even within the surgical setting of cardiac surgery or orthopedic surgery, the rate of HIT is different, and also the type of heparin being used also impacts the prevalence of the disease. The pathophysiology of disease starts when an individual is getting heparin, especially in a surgical setting. When you get heparin, the amount of, and with an increase in the circulation of a protein called platelet factor 4, this is a self-protein that is stored in the platelet, and upon the activation of platelets, you get an increase in the circulating amount of platelet factor 4, or PF4, which can go up by 1,000-fold. Heparin is a long molecule. It's electronegatively charged. PF4 is a tetramer or a dimer of dimers, I'm told by my friends in crystallography, and it's got an equatorial positively charged ring around it. They combine to form large immune complexes. For whatever reason, PF4 and heparin complexes, and there's been a lot of speculation, induce the immune system to produce antibodies against that complex. The complex ends up forming an immune complex, which is IgG antibodies bound to the complex. Those, in turn, bind to the platelets at the Fc gamma R2A receptor, cross-link the receptor, and activate platelets. Of course, when you activate platelets, you spill out more PF4. Now you have more PF4 to bind more heparin to make more antibody, and it's a vicious cycle which can't stop unless you stop platelet activation. It leads to a very high rate of a procoagulant state, which requires immediate intervention. Now, it's a high-stakes operation. Clinician is dealing with a thrombocytopenia that is hard to recognize as being HIT or not. That could lead to a high rate of thrombosis. It's about if it's not recognized, it's about 6% daily risk in the first few days, which can go up to 40% risk of thrombosis in the later days to weeks. If you do recognize it, you want to stop heparin, and you need to switch to a different anticoagulant because just stopping heparin is not going to do the job. If you misdiagnose and they do not have HIT, and you actually switch the anticoagulant, then you expose them to an increased risk of bleeding at about 1%. And not to mention the high cost because of the drugs that are being used and the extended hospitalization. But the reality is the clinician is dealing with a situation that needs to be resolved right on the spot or really close to that time because it's during cardiac surgery, orthopedic surgery. So our job becomes to be able to help them with the diagnosis. Ted Workington from our group, in collaboration with John Kelton and the group, developed a clinical suspicion assessment tool called the 4T score. Now, I'm not going to pretend like I know this the way it works bedside, but there are elements that allow you to assess and predict whether this could be HIT developing or not. It includes thrombocytopenia, and for, thrombocytopenia is defined as platelet count lower than 100, but that's not true in HIT. In HIT, it's a 50% drop from baseline before heparin. So that's the first thrombocytopenia that is going to be difficult to recognize. Timing, it's not immediate thrombocytopenia as soon as the surgery starts. It's between 5 and 15 days. So you want to recognize a 50% drop in platelet count 5 to 15 days after initiation of heparin therapy. And you're giving a score here, and as the score gets higher, the chances of HIT become higher. Thrombosis, the potential development of a thrombosis if recognized, and other causes, ruling out other causes that could lead to this development. If you have a low score, that's great, because the chances of HIT, the positive predictive value, is about 0.2%, so you can rule out HIT. If you have an intermediate or high score, you need to test. Do laboratory testing to be able to confirm if it is or isn't. So the tool is good to recognize that. That said, some of the studies also from Hamilton had shown that there's a big variability in using this tool amongst clinicians, those that recognize it better than those that don't. So we pretty much are informed that our laboratory receives samples for HIT testing from the country based on an intermediate to high preclinical score, but we know there's many of them that actually are low. So how do we diagnose it in the lab? Well, you would think that it's easy. Just tell us if there's an antibody. If there's an antibody, then you have a disease. So it's an easy immunoassay, but that's not true too. Immunoassays are like ELISAs or EIAs. Pretty much tell us if there's an antibody. You put the antigen in the plate. You come at it with patient serum samples. You ask if there's an antibody. If yes, then this is an anti-PF4 antibody that could cause disease. The problem is many patients exposed to heparin will produce an anti-PF4 antibody that does not cause the disease. Upwards of 80% of patients. So this study was done by John Eichelboom and Ted Workington in Hamilton. They looked at cardiac patients and I believe orthopedic patients and recognized that 80% of the patients will produce an antibody, but less than 1% will actually have HIT. So why? We don't know why. There's a high rate of seroconversion amongst patients, and it's only the antibodies against platelet factor 4 and heparin that can activate platelets that can cause the disease. And that's where the functional assays come in. This assay, one of these assays are the serotonin release assay, which was developed decades ago by John Kelton and the group. And basically it tells you, you take washed donor platelets, you mix them with patient serum and increasing amounts of heparin. If you get platelet activation, that's HIT. The sensitivity and specificity of the functional assay is close to 100%. The problem with the functional assays, as clinicians know that have sent these samples to us, it's not widespread. There's a handful of labs in the world that can do this test, and it takes about 3, sometimes 5 days to get a result. So timing is very important in this setting, and the functional assays are not quick enough. They're accurate, but not quick enough. The ELISAs have a high false positive rate because patients will produce an antibody that does not cause the disease. The beauty about the ELISAs is they have a high sensitivity and a high true negative rate, which means if you don't have an antibody, you don't have the disease. It's great, so we devised an algorithm. We use the ELISAs to rule out the disease. It can be done in one day, but those that are positive have to wait for for a functional assay to tell us if the patient has the disease or not. So these are the assays mostly used worldwide for diagnosing HIT. There are newer assays. They're very expensive. They're large platforms. They're called these rapid immunoassays. There's two flavors of them as we know right now. There's one that is called the latex immunoturbidimetric assay. This one is sort of a functional immunoassay because it's based on can you form a large immune complex to cause this turbidity, and if the patient sample can break up the complex, then it's closer to the disease. And the other one on the far side is more like an immunoassay. It's just quick. Is there an antibody against PF4 heparin? So these work well, but they have a high sensitivity, not close to 100%. So sometimes you'll miss HIT patients, which is never a good thing. The specificity is still mediocre. So needed improvement. We tried to improve on that by combining both assays in different algorithms. Our algorithm was a simultaneous one, which we test in both assays. If you're negative, you're negative. If you're positive, then you probably have the disease. The second one is done by a British group. It's a sequential. Test in the first. If you can't get the result, test in the second and assess based on that. Both of them had an improved sensitivity, and the specificity was better than the ELISAs, but still not good enough. The problem with this, it's nice and quick. 25 minutes, you can get the result, but it becomes very expensive to run these tests by a 20 time fold. So, and they're not that available. So what did we do? So we used basic science, pretty much molecular biology, to try to understand this. I had a PhD student, one of the smartest people I've met in my life, Angela Wynn, who did her PhD, and she developed this platform. This platform takes platelet factor 4 and mutates every single amino acid on its own. It takes the amino acid, it changes it to alanine, and if it's at alanine, changes it to valine. Pretty much telling us at that site, is that amino acid important for binding or not? So she made 70 copies of this. And for those who purify proteins, she had to purify 70 versions of the protein. So if you're using columns and you know what I'm talking about, that's the only way we were able to get our CFI, because I pretty much told our VPR, we purify more proteins than the entire department of biochemistry. So he's like, point taken, you can get a CFI. So her question was, is there a version of PF4 that can identify the pathogenic anti-PF4 antibodies from HIT patients from those that are non-pathogenic? Do they bind with different specificities? Can you produce one that will have a higher, maintain the sensitivity of the assay, the ELISA, but improve on the false positive rate? Well, she did her PhD. She really didn't get that result she wanted. She couldn't really separate and produce an ELISA based on that. And that was the end of her PhD. She went on to go do medical school, and then during medical school, which was during COVID, it became online. She came back to Hamilton. She's like, I need a job. So I gave her a job. She worked on COVID, and VIT hit, and she was the one that was doing this work. And she was able to use this platform to discover how VIT works in 6 weeks. From the first sample of VIT in Canada to a Nature paper that she's first author on, she took 6 weeks because she developed a platform that she was trying to use for improving on HIT, but she ended up with a Nature paper, which was followed by an NEJM paper because of her work. She's brilliant. What she didn't recognize during her PhD is, although the mutants are all over the place and they can't separate the pathogenic from non-pathogenic, when she came back and she was playing around because of VIT and COVID, she was playing around with her project, and she noticed that despite the fact that pathogenic anti-PF4 heparin antibodies from HIT have different epitopes, so in other words, they bind different amino acids on PF4, they're all localized in one spot on the protein, that being B. They're all in one spot. The non-pathogenic ones, which are the antibodies being produced during heparin surgery but don't cause the disease, are all over the place. They're not in one spot. Now, it's not monoclonal, as we see in VIT, but it is focused in one spot. There's a lot of antibody there. There's a monoclonal antibody that was developed by, I believe, the Philadelphia group, KKO, and this antibody behaves like HIT, and it also binds in the same spot, which means an antibody to this spot is capable, for some reason, to activate platelets. So, what did we decide to do? Well, if that's the separator between pathogenic and not, it's the location. Well, we took KKO, the monoclonal antibody, because we know the sequence of the heavy and light chain, variable heavy and variable light chain. And we produced something called the SCFV, or single chain variable fragment, which is just this piece right here, which takes the two pieces that actually bind the antigen without all the accessories of an antibody. And we produced it in E. coli. And the idea is that if it can bind to the area where the pathogenic antibodies bind, it can knock off the antibody, and you can get a separator of pathogenic versus non-pathogenic. Sure enough, we used this SCFV that she created. She created multiple SCFVs. The group created multiple, and we took the one that binds best, and we put it into a commercial ELISA that is used for HIT testing. That's the far one over there, the Immucor one, and two commercial ones which use different platforms to assess antibodies against PF4 heparin. And you can see when you take HIT patients right here, and you test them without the SCFV added, and then you add the SCFV, you can see that you get a big knockdown in the presence of the antibody. And when you take the non-pathogenic antibodies and you add the SCFV, you do not inhibit a lot. And it translates into all the different platforms that we used. She used the group used an ROC curve to determine the best cutoff to determine how the SCFV can improve on the false positive rate of the ELISA. That's the most important part, without sacrificing the sensitivity. So we set the sensitivity to capture every HIT patient and see how much we can improve on the false positive rate. And in the first assay, which is the streptavidin-based assay, we improved on the false positive rate by 72%, which is great. That means 72% of the samples do not need to be further tested in the serotonin release assay. In the anti-PF4 heparin assay, that is in the in-house one, we improved it by 73%. And in the Immucor, which is the commercial-based assay, we improved the false positive rate by 41%. Again, about 50% of the samples now do not require an SRA and can be reported immediately after the ELISA is done, which takes 1 day. So now the beauty about it is that it improves on the ELISA, but it potentially can go into the rapid immunoassays also, which take 25 minutes. And be able to decrease the false positive rate over there. So we developed a tool in the lab using basic science so that we can improve on diagnostics, create new assays that are able to improve on patient management. By increasing the speed, we can report the results and enhancing on the accuracy of the assays. This is the last thing I want to show. This epitope mapping profile was able to allowed us to be able to understand the antibodies from patients in HIT. And what we did recognize during that time is most patients in HIT will make an antibody, this is the far left, make an antibody to the north pole of PF4. That's where they sit. That's where that SCFV sits, so it knocks off most of the antibodies. More importantly, what we notice is that there are these atypical HITs, which some of you might know if you know HIT as autoimmune HIT. This comes with more severe thrombotic events. They might benefit from different treatments. We know the IVIG and autoimmune HIT might help patients even outside of just switching to a different anticoagulant. However, right now we just report HIT or not HIT. We think that if we can improve on our diagnostics, we can help clinicians be informed on how potentially to manage patients in a better fashion. We learned these lessons because we dealt with VIT also. And when VIT happened, there was this big thing, can we use heparin or can we not use heparin to treat these patients? And the fear of HIT said, no, don't use heparin. But some clinicians across the world have recognized an improvement when using heparin. Why and some not in others might be because of the profiles of the antibodies produced in VIT. How does our understanding of disease mechanisms help us to improve on diagnostics and treatments? Well, on the left-hand side, which is HIT, this is to reach this stage, took 40 years of understanding HIT. on the other side, because we understand HIT, when VIT started in Europe, it wasn't here in Canada just yet, but we were ready for it. We knew it's an anti-PF4 antibody that causes a disease similar to HIT. In 6 weeks, we were able to understand the disease and devise a new treatment approach because we understand the disease. So for those that are, training new, understanding disease mechanisms from previous diseases that apply to new diseases will, in fact, help us deal with a situation like VIT, which was very catastrophic when it was happening. There's no success, obviously. I get the pleasure to talk about all of this, but the reality, this is the group that does all the work. I have great mentors, Dr. Arnold, Dr. Kelton, Dr. Workington. We have a phenomenal group, and of course, there's no work that can be done without proper funding. So thank you very much for your attention. Happy to
That was fantastic. Just to comment that, I wonder if this could be applied to therapeutics too, because just talking about autoimmune HIT, in Earl Davies a couple of years ago, we were talking about it, and we were talking about IVIG as a therapeutic for that. And when you mentioned that the light chain, the SCV, how it knocks off the pathological one on PF4, and we were speculating maybe IVIG, that's what it's doing. It's knocking off the pathologic antibodies. So I wonder if this could be applied to therapeutics and not just diagnostics.
So that is the hope, that it improves on diagnostics, but at some point, if it can get into a clinical trial, which is really hard in the world of heparin-induced thrombocytopenia, we think it can do that, because we've actually taken the SCFV, it's data I didn't show here, but we have taken the SCFV and we put it in the functional assay, which stops platelet activation, and we showed that the SCFV can actually stop platelet activation mediated by the antibodies. So there is potential for it, except clinical trials in HIT are not easy. So there is hope, but yes. And SCFVs have been used previously in other disorders as a therapeutic. So there's room for that too.
Isaac, great talk.
Thank you.
Two things. One, I didn't see complement in your putative pathway in terms of the pathogenesis of HIT. There's been really interesting studies by particularly Doug Seens and Gower Rapella. Pele, maybe you can comment on that. And then the second question was related to HIT without the heparin. My understanding is, and maybe the clinicians can help me, but rarely there are HIT-like syndrome in any case, and I wonder about the role of other polyanions such as polyphosphate. So 2 questions.
Amazing, yeah. So as far as the other mechanisms in HIT, there's no doubt that was the summary of the stuff I work with, on. Complement definitely plays a major role. These immune complexes also activate monocytes, which produce tissue factor, activate the coagulation cascade, and more recently is nitosis. So these immune complexes also activate neutrophils that secrete their nets, and they contribute to the thrombotic events. So there's no doubt there's many elements that are playing a role. And I honestly believe, I know there was a lot of talk on antibody-mediated phagocytosis. These antibodies also contribute to thrombocytopenia by phagocytosis also. For your second question about HIT-like syndromes. So spontaneous HIT is one type of HIT that is sort of not really associated with heparin. For years, patients would present, and it's rare, but patients would present in the hospital because they have an infection and they have a thrombotic event that looks like HIT, but without proximate heparin use. Recently, with Ted Workington, we just published a paper in NEJM of 2 patients for the first time confirmed that their spontaneous HIT was downstream of an adenovirus infection. One of them had CVST, and CVST has become a hallmark of VIT. 50% of VIT patients have CVST. CVST is a very rare clotting event in the brain. So they did have CVST, and they did. So what the polyanion over there was it really the adeno, or was it polyphosphate or something else? I don't know. But that in itself also is the same for VIT. We really don't know what the what causes the immune response to produce an anti-PF4 antibody? Is it the surface of the vaccine, or is it the DNA in there, or other polyanionic factors in there? Now, some spontaneous HIT patients present with very similar profiles as HIT, and despite the fact that there isn't a lot of heparin use, but in orthopedic surgery, you'll get glycosaminoglycans released into the circulation, which can play a major role in complexing PF4 and potentially causing the same mechanism as heparin, the real heparin, during heparin therapy. So.
Ed, Dieter. Go ahead, Dieter. Speak.
Yeah, very interesting. So is there a kind of a different binding area for the heparin and for your HIT antibody? So if the HIT antibody binds on PF4, so where is the heparin? Is it next to it? Get it pushed away? And why in VIT, where you don't need heparin, but the antibody also binds in a little bit different area, causes the same disease? So I still don't get this connection. Why this? What's really the difference?
So I'd love to know the answer, because then we would become really rich in making vaccines using adeno vectors. But the red area is where the VIT antibody primarily binds, and that's the heparin binding site. We did show in that paper that heparin, just the slightest amount of heparin, will knock off the antibody. So I thought at first, when we were writing our guidelines, is that the heparin actually might be good. But there was fear. Of course, nobody's going to recommend the use of heparin. But later on, the presence of heparin seemed to benefit some patients. Now, whether it benefits the patients with the 2 antibodies or the 1 antibody, I don't know. It could potentially be that. Why we're getting antibodies in the second one, this is a dimer of dimers. So when heparin binds one side, the other side doesn't have heparin binding to it. So that antibody can still bind because it's got 4 sites, 4 identical sites. So despite the fact that sometimes heparin is there, the other site of the heparin binding site, the antibody can bind if you have a red antibody. Does that answer your question, or not really?
Go ahead. Last one.
Isaac, thanks so much. I've always wanted to ask a HIT expert this question. Nobody has looked in the literature, but is it conceivable that HIT is induced by rare neoantigen expression through proteolysis of PF4? Nobody has looked for this.
Yeah, that's a great question. So one thing we did at some point when I first started was take PF4 and create overlapping peptides. So your question is in relation if the proteolytic pieces can induce a T cell response? Is that what you're trying to get to?
It could be.
Okay.
Yes.
So we took those peptides, we mixed them with HIT PBMCs and healthy control PBMCs, and we did not see an induction of proliferation or any production of the antibody, despite the fact that if it was a T cell mediated immune response, they should have proliferated, or at least proliferated, but maybe even produce an antibody.
And disulfide interactions within PF4, I'm not aware of that.
Disulfide?
Yeah, how will that
So there
contribute?
are 4 cysteines, there are disulfide, and if you break the disulfides, the actual tetramer breaks apart, and heparin can't complex it anymore, and antibodies can't bind them anymore. So that is important.
And antigen presentation may not have an effect in that context.
Correct, because antigen presentation is just going to be a 10 mer or an 8 mer or 14 mer, right? But great point. Thank you.